Let's take a look at X-ray technique selections and how they impact your images. For exposure issues, anatomic programming and AEC work very well for the average patient, but do they work for all patients? We're going to review how manual techniques can actually reduce repeat rates and improve imaging on difficult patients. In addition to exposure techniques, a knowledge of anatomy, physiology, and positioning is critical. This is especially true when trying to locate mastoids, zygomas, or other areas in the skull. Here we can see how important it is, even for a simple radiograph like a KUB. Body habitus does make a difference. Osteology is the key to palpating surface anatomy in 2D projection imaging. Surface anatomy is the study of the structural relationships of the external features of the body to the internal organs and parts. The skeletal system provides a standardized reference that can be palpated for positioning. Knowing where the internal anatomy and organs are located with respect to the skeletal system also allows the radiographer to position areas of interest that cannot be palpated. Let's take a look at some of those areas that you can't palpate for positioning. We begin with the brain, which is the portion of the vertebrate central nervous system enclosed in the skull and that integrates sensory information to the body. Next, we see the lungs, liver, heart, stomach, and kidneys. All of these essential organs are subject to both trauma and disease pathology. Knowing where they are and the physiology of how they work is crucial in producing diagnostic imaging exams for interpretation. Inaccurate positioning of the area of interest to the image receptor, along with poorly collimated exposure fields, often result in poor quality digital images. Positioning errors is the number one reason for repeat digital radiography exams. This sample positioning guide of the AP lumbar spine demonstrates not only where the central ray is to go, but what is to be demonstrated and the evaluation criteria for the radiographer. Understanding imaging processing and creation in digital is far more important than it was in film screen radiography. Using the photographic process in film screen radiography, you were only able to produce one image, and it was easy to see because of the small dynamic range if it needed to be repeated or not because of contrast or positioning. Also, the artifacts shown on the images could be used to determine what to correct in equipment and processing errors. We can notice the difference between a film screen versus digital shades of gray or dynamic range. Unlike photographic processing, digital imaging requires the mapping of thousands of shades of gray onto a matrix or a digital matrix, which can be viewed on an imaging monitor. Without a radiographer who is very knowledgeable about anatomy and positioning, automatic timers are worthless. In fact, they may actually decrease department efficiency because of the increased amount of repeat radiographs that will result if used improperly. If you understand anatomical programming and automatic exposure control, things are great, but when you don't, you have a problem. Automatic exposure does not relieve the technologist of the following obligations. First, skill in positioning. Next, technique selection. Still needed to select MA and KVP and backup time. Anatomic recognition. Different parts require different settings. And awareness of the idiosyncrasies of each piece of equipment you are working with. The GE is different than the Siemens that is different than the Philips. In digital imaging, positioning is critical because you're trying to match the anatomy to a expected image of the anatomy. The computer can only correct for so much, so if your image is not positioned correctly, you may end up having an exposure index number that is way off and you have pixel shifting. Remember, the computer is expecting a certain range of exposure. If you do not use collimation and positioning, you may end up not being able to get the data to the computer it needs to create the image. When we collimate, it changes the actual beam quality. And what we find is there is a difference in recorded detail. With inappropriate collimation, the exposure index is off and the image is degraded, as the image algorithm must factor in information not related to the anatomical image being created. Even though both these images are collimated, we can see the difference when the centering and collimation differ on the same phantom. One of the things that we found with the ASRT and taking a survey of 450 technologists was that they didn't understand the difference between collimation and masking, and therefore did not collimate on the acquisition, and then tried to make the image that they did acquire look as if it had been collimated. The problems with this misconception is that they were over-irradiating the patients, the images were degraded, and the radiologist only saw the area that was masked off and therefore could miss pathology that was acquired on the original image. Image post-processing is not a panacea for mistakes. Misuse of image processing includes compensating for inappropriate radiographic technique or compensating for poor calibration of acquisition and display devices, or compensating for surreptitious deletion of non-diagnostic images. Image processing to recover a non-diagnostic image to prevent re-exposure should be a last resort, not a routine activity. Routine reprocessing indicates a problem with automatic image processing or technical practice. A best practice in digital radiography is to use exposure technique charts that are continuously improved and applicable to a wide range of patient sizes. Anatomical programming is actually an electronic technique chart designed by the manufacturer. Once you get your equipment, you should modify that technique chart to reflect the type of exposure for your facility and radiologist. Many radiographers do not know how to go in and modify this electronic technique chart, therefore limiting their ability to use their equipment. Understanding the factors that are required in creating a technique chart is important, and the ability to create a technique chart, especially for your mobile radiography. The technique chart should be based upon the anatomic part to be visualized, the grid ratio being used, the kilovoltage peak, the MA, central ray location, part thickness and measuring points, and the type of image receptor being used. Also, the position or projection, focal spot size, and the SID or source to image distance. The technique charts are only the beginning of creating the exposure for the patient. The charts don't take the place of the radiographers carefully assessing individual patient pathology, the conditions in which the radiographs are being made, and any unusual circumstances, because the charts are designed for the average or typical patient. When you're formulating technique charts, you should understand that a technique chart should be established for each X-ray tube, including the portable units. There may be a difference in the output between one room, the portable unit, and another room. Departmental standards for radiographic quality should be established and used as the basis for formulating the technique chart. The radiographic equipment for which the charts are developed must be calibrated. Imaging processing must be consistent throughout the department to produce the radiographic density and contrast that you desire. When you hear the room is shooting too hot or too light, it needs to be calibrated. To standardize exposure techniques according to patient size, procedure, and precision, you need technique charts that provide consistent and accurate radiation exposure to the image receptor and also establish department standards that eliminates confusion and concern regarding appropriate use. Appropriate use would be the correct selection of KVP, MA, grid, and SID that produces an acceptable level of radiation under the standards of the ALARA as low as reasonably achievable principle, and also provides the best diagnostic quality image. Technique charts do not replace the critical thinking skills required of the radiographer. The radiographer must continue to use individual judgment and discretion in properly selecting exposure factors for each patient and type of examination. The radiographer's primary task is to produce high-quality radiographs while delivering the least amount of radiation exposure. Technique charts are designed for the average or typical patient and do not account for unusual circumstances. These atypical conditions require accurate patient assessment and appropriate exposure adjustment by the radiographer. Exposure technique charts should be monitored and revised continuously to ensure these techniques are producing diagnostic images within the ALARA principle. Now let's look at a fixed technique chart that is manual. It's called a variable KVP fixed mass technique chart. And what this is the mass is fixed and the KVP varies as the size of the anatomy increases. Specifically, the baseline KVP is increased by 2 for every 1 centimeter in part thickness increase, whereas the mass is maintained. The variable KVP technique charts may be more effective for pediatric patients or when small extremities are being examined. The next chart we'd like to take a look at is the fixed KVP with variable mass technique. What happens here is we find an optimal KVP for the type of tissue that we're examining, and we change the mass based upon the thickness of the tissue as it increases. This is routinely used in chest radiography where we want 100 plus KVP. You find the optimal KVP and leave it fixed, and then as the patient's size increases or decreases, the mass increases or decreases proportionately. This works well on the average patient, but if you get a very, very thin patient or one with COPD or a very obese patient, you have to manually set your technique appropriate for the pathology that you're trying to demonstrate. The thing that hangs on the wall that nobody uses is called a caliper, and it's to measure patients. I just joke that nobody uses it, but most people think they can eyeball it and figure out just how thick the patient is. Using the calipers, we can get a baseline measurement and then utilize our knowledge about tissue, such as adipose tissue or COPD, to change the techniques appropriately. In most cases, we won't have to change the technique because it will be adequate as it is for the average patient. Now, there are a number of special considerations when setting your technique. What happens if you have a patient that has a cast, or maybe you have a trauma patient that has a bullet wound or something like that, and they still have the bullets in them? How do you adjust your techniques for those types of things, and how do you adjust your techniques for pathologies? Pathology that may be very dense, or pathology that may have a negative density to it, such as COPD. Now, here's one we should be familiar with over the past few years: normal versus COVID. Here we see a difference in tissue density with a pneumothorax. Notice that the lung has collapsed, and so there is no lung markings in the collapsed portion, whereas the other lung has lung markings. Now let's take a look at the density differences between a pneumonia and a pneumothorax. Notice the pneumonia is solid, whereas the pneumothorax is a minus density. Let's do another clarification. Anatomical programming is not the same as automatic exposure control. They are not related in their functions, but both of them can make a difference on exposure. Anatomically programmed radiography is a system of pre-programmed exposure techniques that is organized by position and procedure and set throughout the control panel of the radiography unit. These APR settings commonly provide recommendations for small, medium, and large patient size and include a combination of AEC and manual exposure technique settings to choose from. When the automatic programming is used in conjunction with AEC on some radiographic units, the APR system not only selects and displays manual exposure factors, but also selects and displays the AEC detectors to be used for specific radiographic examinations. It is critical that if using the AEC, it be properly selected to match the image receptor systems before clinical use. AEC or automatic exposure systems use radiation detectors called ionization chambers that are pre-programmed based on phantoms. The purpose of an AEC is to deliver consistent, reproducible exposures across a wide range of different situations, including a different anatomical thickness, different types of body and parts being imaged, different types of equipment, different techs using the equipment, and different rooms that contain the equipment. Radiographers must have a sound knowledge of how automatic exposure control works to be effective in dose optimization. They need to select the correct field or sensor and accurately position the region of interest to the sensor field. Now, if the part is smaller than the sensor field, you should not use an AEC, or if the values of interest contain something like a prosthesis, such as in a total knee replacement, you would end up with metal being over the sensor field and creating a poor exposure. A best practice in digital radiography is to use automatic exposure control when indicated, and to use the AEC that has been calibrated to the type of image receptor to provide a consistent exposure to the image receptor. We use manual technique when we have something like a total knee replacement or a different type of material that we need to go through than the AEC is expecting. Automatic exposure controls need to be calibrated for each room because each tube has a different output. Physicists have to be sure that the AEC is calibrated accordingly to digital systems and not a residual screen film system. To properly expose digital radiographs, the physicists must recalculate the KVP correction curve to the AEC system to respond correctly to the receptor characteristics. Exposure indicators only work when they are calibrated correctly to the equipment. Your exposure indicator tells you what the exposure really was and if you are over or underexposed. Your monitor image that you're looking at is based upon the algorithms for the histograms being used and will display the exact same image whether your exposure is 20% underexposed or 500% overexposed. This is very different from film screen radiography where what you see is what you get. Having automatic exposure control does not relieve technologists of the following obligations. 1. Skill in positioning. Next, being able to select the techniques correctly for MA, KVP, and the backup time. The radiographer must know the values of interest for each anatomical part that they're trying to recognize, because different parts require different settings. Finally, each manufacturer has their own equipment settings or idiosyncrasies. Has digital with anatomical programming made AEC obsolete? Absolutely not. While digital equipment will override image density provided by an AEC using anatomical programming and lookup tables, the AEC is still a help. It helps to limit patient exposure and also provide enough exposure for the images that you're trying to create. In the beginning of digital, exposure recordings were all over the place with S numbers and this and that. Today we have standardized exposure index numbers. In modern digital radiography systems, there is an inbuilt detector dose indicator. The detector dose indicator, or DDI, gives an indication of the level of radiation exposure received by the detector. This is useful for monitoring that the exposure is the correct range for the optimal image. It is important to understand that the image that you're looking at on your monitor after exposure has been corrected by the computer to appear like the image that you requested. The DDI reflects the actual exposure the patients received. When using anatomical programming with automatic exposure control as opposed to manual technique, the amount of radiation exposure for an imaging test depends on the imaging test used and what part of the body is being tested. For example, on an average person using a chest technique for a PA chest, you'll find that a single chest X-ray exposure is about 0.1 millisieverts. This is about the same amount of radiation that people are exposed to naturally over the course of 10 days. Very, very little. For digital imaging, exposure indicators only work with calibrated equipment. This is important because with digital image, you have a wider range of shades of gray. That means that the technologists have to pay attention to exposure indicator values instead of brightness and contrast of the image that they see on the monitor, which has been corrected by the computer. Both radiologists and technologists will need to understand the three terms exposure index, target exposure index, and deviation index to understand the standards of the IEC and AAPM. AAPM is the American Association of Physicists in Medicine. Exposure indices and deviation indices were implemented across all digital radiography detector types and across all manufacturers and vendors of such equipment many years ago. It is the manufacturer's responsibility to calibrate the image detector according to a detector-specific procedure. It is the user's responsibility to make sure that the equipment remains calibrated during the usage period. With digital imaging, the only way to objectively identify whether or not a patient risks being exposed to too much radiation is to review the exposure indicators provided by the imaging system. Optimal exposure index and deviation from the DI or dose indicator numbers will tell you if you have an optimal image. Many times you'll find that manufacturers' exposure indexes are set too high, and it is recommended that you go through them when you receive your equipment to reduce patient dose. The increased dosage reduces quantum model, and the image appears great to the human eye, but may not be preferable to patient dose. Dose can be reduced and an acceptable image produced by using less mass. Thank you for your time and attention. This is Mark Struthers.